As we know, right, the COVID pandemic has certainly impacted patients with kidney disease disproportionately. Chronic kidney disease is one of the major risk factors for hospitalization from COVID, but unfortunately, patients with kidney disease were not really included proportionately in the vaccine trials, right? So a lot of what we're trying to understand about the impact of the disease on glomerular disease pathogenesis and flares, it's really just now being understood a little bit better, and certainly the efficacy of vaccines, right? Something that folks have a lot of questions about. So happy to be presenting with my lovely wife. All right. So I'll be just briefly talking about a little bit of the pathogenesis of SARS-CoV-2 infection, COVID-19 disease, and Dr. Shaikh will pick up on vaccine overview, efficacy, therapeutics, the impact on patients on dialysis or with a kidney transplant. And then I'll come back to talk a little bit about the impact of COVID-19 in glomerular disease. So, what's in a name? So, just a little bit of terminology that initially confused physicians and certainly folks from the lay perspective. Coronavirus is really belonging to a large family of viruses that can cause disease in humans and animals, right? And SARS-CoV-2 is this particular strain of virus that's causing this pandemic. The disease that's resulting from SARS-CoV-2 infection is COVID-19, right? And that's the constellation of symptoms that we're going to be touching on a little bit. So, of course, what we do know so far is that the likely origin of the coronavirus was a bat, but there's an intermediate host that's still as yet unidentified before humans eventually became infected. And this is a bit unlike some of the other coronaviruses where we actually know the intermediate host, right? So still a little bit of a mystery there. And so the virus has this complex structure with the crown, the spike protein, which Dr. Shaikh will be talking a little bit more about because that's really important for viral entry and a target certainly for a vaccine development. But this is an RNA virus with the complex structures include a nucleocapsid protein, which is a part of the way it's identified as well in some of the assays, which we'll touch on in a bit. So this spike protein is part of the pathogenesis for infecting cells, usually epithelial cells, via this ACE2 receptor, right? So, the cells that have this receptor, it'll bind to the spike protein, and that's one of the ways, right? That's the way that the virus will actually enter the cell, and it eventually replicates and spurs a cascade that involves a lot of inflammatory mediators, right? So the inflammatory cytokines, the inflammation that develops, the secondary bacterial infection, right? The initial, original strains of COVID before these novel variants came about had a significant lower respiratory component with a bacterial pneumonia as a superinfection. But it's a multi-organ system disease, right? And literally from head to toe, different organs can be affected. And of course, the kidney is very much a part of that, right? So acute kidney injury, proteinuria, hematuria, some of the associations that we've seen, and we'll talk about a little bit later. Unfortunately, the acute infection is not necessarily the end, right? You've heard a lot about long COVID and the chronic symptoms that can result from acute COVID-19 disease, and this, of course, can affect multiple organs as a result. And again, that's still being studied, and the therapeutics and vaccines may help to ameliorate some of those clinical findings. So I think with that, we'll transition to COVID-19 is ready. So disadvances, that's a pointer. Yeah.
Thank you. Thank you, Kristen, for such a wonderful introduction, and thank you to NephCure for inviting me to speak today, and thank you, Dr. Campbell, for such a brief and yet meaningful intro to this talk of mine. So, as you heard, that we in New York City were hit with this pandemic early on, and we were hit hard. And most of the data that I'll present will take you through where we were in 2020 and where we've come with vaccine efficacy and with the Omicron virus infection, especially in both dialysis and kidney transplant patients. So the talk today would be first focusing on the morbidity and mortality of COVID-19 in patients with kidney disease, specifically end-stage kidney disease. Then I'll talk about the antibody response to the SARS-CoV-2 vaccine. And last, I will talk about COVID-19 therapies with the caveat that literally the recommendations are changing at a head-spinning pace. So what I may say today may not necessarily hold true in terms of agents that are available or still maintain efficacy against the current COVID or SARS-CoV-2 variant. So I think the one part we can all agree upon in this room is COVID-19 infection had a disproportionate impact on the patients that we see, meaning patients with end-stage kidney disease. And this was evident to people who were on the front lines very early on, including myself. But the general public didn't become aware of it till more recently. And this USRDS COVID-19 supplement was published, which actually made people sit up and take notice. And again, we were experiencing this firsthand early on in the pandemic, and it took a while for people to realize. Take a look at this graph, and this is the rate of COVID-19 hospitalizations that happened during the pandemic. This is early part of the pandemic, so this data is 2020, so 8th week of 2020 is beginning of March, and that's where the pandemic started affecting or impacting our population. So 11,200 hospitalizations among patients on dialysis occurred during this phase of the pandemic. That's a big number. And if you look at the patients who were being hospitalized, 3 to 4 times higher rate of hospitalization was seen among hemodialysis patients versus peritoneal dialysis patients. And I use this graph to tell people that there has never been a stronger argument for home therapies than the COVID-19 pandemic. And this is honestly something that we, even as physicians, saw firsthand how big a proponent of peritoneal and home hemo we all became when the pandemic hit us. So alarming thing is not just the hospitalizations that happened due to COVID-19. What's even more alarming to me when I look at this USRDS data is take a look at non-COVID hospitalizations. They were 24% lower during the same time period. Think about that. Dialysis patients didn't start having fewer medical problems when the pandemic hit us. It just means that perhaps people were not seeking care or didn't have access to care because the healthcare system was so overwhelmed with COVID-19. And this affected our patients. This is not a number that you can ignore, a 24% decrease in hospitalizations for non-COVID related diseases. Now, this should stun everyone, and this mortality rate from our unit I will share with you in a second, but this is the USRDS data. So if you look at early on in the pandemic, week 14 to 17, the mortality rate went up by 37% among end-stage kidney disease patients on dialysis compared to previous years in the exact time frame. Take a look, 37% excess mortality. Now that number did improve to that did improve later on, but still 16% higher. This is later on in 2020. So this impact was all during 2020, even though it improved a little bit. And unfortunately for New York City, where we practice, we were caught in this early phase. Now, if you look at the mortality rate among kidney transplant patients, that actually also went up during the same time frame. So if you look at week 14 to 17, the mortality rate among kidney transplant patients was 61% higher compared to the same time frame in years prior. This too improved in the latter half of 2020, but nevertheless, it stayed at around 26%. Now, the absolute mortality rate among transplant patients was 1 death per 1,000 patients per week, which is still lower, significantly lower than dialysis patients, which was 4.2 deaths per 1,000 patients per week, but still an astounding number. Now, if you translate the mortality rate among dialysis patients, that comes out to be that 18,000 more patients died in 2020 who were on dialysis than in 2019. And this represents an increase in mortality of about 20%. And people did not recognize this. We knew it because we were witnessing this in our dialysis unit, but with the publication of USRDS and more media took attention of this. And this article was published in ProPublica, which truly, I think, nailed it. And they called end-stage kidney disease patients as the perfect victims of the pandemic. And it was the first time in 50 years in the United States that the dialysis population shrunk. And these patients did not get the attention, whether it was in the media or otherwise, early on when the pandemic really was affecting them. So why is it that end-stage kidney disease patients who are on dialysis were so impacted by this pandemic? So I can't think of too many diseases where patients' risk of acquiring an infection was as high as in-center dialysis patients. You have to travel to and from dialysis units, so you're potentially exposed to the virus. I can't tell you how many patients of mine in New York City I could trace back the infection in the van they were traveling in. And this became a huge issue for us because we wanted to isolate them and separate the other patients, but things were moving so fast for us that we almost couldn't keep up with following all these patients that travel in a group setting in different or various forms of transportation. Time in waiting areas, time in the dialysis unit. Now, we all tried to change that pattern during the pandemic, but you can't minimize it to a zero. A lot of our patients reside in long-term care facilities. That is in itself a huge risk factor for exposure. And then when we talk about mortality, the mortality is not just from the COVID-19 infection, but the lack of care for other conditions because the healthcare system is so overwhelmed and patients are scared to go to hospitals if they don't absolutely need to. That led to a higher risk of complications in this patient population. And then the biggest thing is our patients are immunocompromised. A lot of them are belong to the older age group, which we know tends to carry a poor prognosis for COVID-19 infections, and our patients can have a lot of comorbidities. So all in all, these factors are responsible for why end-stage in-center dialysis patients are at risk for contracting the virus and also at risk for complications from the infection. So we actually looked and published this study very early on in the pandemic, even though it says 2021 online, this paper was published in late 2020. And we actually, at the time, were studying our patients who were getting COVID-19, and we showed pretty early on that the shedding of the virus as detected by the PCR test was very prolonged and may not have reflected an actual infective phase. And now we know it's so much more better, but at the time we were still learning. We also showed that the antibody response to the virus, not to the vaccine, remember this study is early 2020, that was pretty decent in dialysis patients, which meant that yes, if they survived the infection, they did mount an antibody response. But what I really want to share with you in this particular segment of the talk is 26% of dialysis patients in our unit between March and June 2020 got COVID-19. And you might say, my goodness, a fourth of your patient population got it. That's a very high number. It is. But it is pretty in line with what we were seeing in the Northeast. So if you look at the seroprevalence data, which means people who got infected and mounted an antibody response, that was about the same prevalence rate in the entire Northeast. And in fact, in New York State, where we are, it was much higher than that, almost 34%. And this is, again, not vaccine-induced antibody data. This is infection-induced antibody data because it goes up to July 2020. And as you know, the vaccines were introduced in December of 2020. So what happened to our patients? Unfortunately, 64% required hospitalization of the ones who had COVID. And among the ones who had COVID, our mortality rate was 27%. Gee, that was high. And this is when other people didn't know what was happening, but as I said, people on the front lines knew what was going on in the dialysis population. So if you look at the data, which is mortality data from in-center dialysis units, it was pretty much in line with what we saw in our unit, somewhere between 25 to 30% among patients who got COVID-19. But I think the biggest message here is this is pre-vaccination data. So things have changed, and I'll go over that data with you. But still, now you can understand that a quarter of patients who got COVID-19 in the early phase passed away, and these are patients on dialysis. So I can't tell you how excited we were when the SARS-CoV-2 vaccines came out. So we looked at our antibody response rate, which I will go over in just a second, but I want to emphasize what Dr. Campbell said early on, that SARS-CoV-2 is an RNA virus. And if you look at the 4 red boxes, those are the viral proteins. So you have the spike protein, there's a nucleocapsid protein, there's an envelope protein, and a membrane glycoprotein. So when the PCR test is done, you are detecting the RNA material, because this is an RNA virus, and that can be positive longer for duration, even beyond the infective phase of the virus. Then when you do a rapid antigen test, which you've probably heard a lot about, you are detecting the viral proteins, and that tends to correlate with infectivity more. And then when you do a serologic test, you are measuring the antibodies to one of these proteins. And the spike protein, as Dr. Campbell pointed out, is a very important protein in the pathogenesis of this virus. So the spike protein is responsible or helps in entrance of the virus into the host cell. And there is a receptor binding domain, which you see in that red mark at the top of the slide, within the spike protein that is the key player here. So when vaccines are given to patients, it is the anti-spike protein or anti-RBD or receptor binding protein that the patient then mounts a response in the form of antibodies. And those are the ones that we now measure to see how good the antibody response has been to the vaccine. Now, in our study, we showed that you can mount a response to other viral proteins. So in our first study, remember, we didn't have the vaccines, and when we measured antibody response to the infection, we measured the anti-nucleocapsid antibody. So the vaccine does not induce anti-nucleocapsid antibodies, it induces the spike protein. So sometimes if there's an issue where you weren't sure if the patient developed antibodies in response to infection versus the vaccine, we would send a panel and we could tell if both nucleocapsid and RBD antibodies or spike were positive. That could mean that the patient did have an infection. It could also mean they had an infection plus they got the vaccine. So it's important when you go in commercial labs, do these tests, what antibody is being measured. So we then looked at the antibody response in our dialysis patients to the SARS-CoV-2 vaccine. And I want to add that this is specifically talking about Moderna vaccine because that's what we had available in our dialysis unit at the time. And we had about 80 patients at the time. Some did not get the vaccine, about 18 of them. In the beginning, they eventually got it, but we didn't include them in our analysis. 61 patients got the vaccine right off the bat. And among those 61 patients, about 20 patients had prior history of COVID-19. So these are patients in our unit who had COVID-19, survived the infection, and then went on to get the vaccine. And then there were about 41 patients who did not, or who were COVID naive. They had not seen the virus before. So what we showed very early on is that 97% of our, or 95% of our patients developed an antibody response to the 2-dose vaccine Moderna series. If you look at the red dots, what we did then is we looked at the antibody response if the patient had prior COVID-19 and compared it to the antibody response among patients who did not have prior COVID-19. So the red dots are representing patients who had prior COVID-19, and you can see how the red dots start rising faster. It was immediately after the first vaccine dose, whereas the blue dots, which are patients who didn't have prior COVID-19, did not see the rise in antibody titers till after the second vaccine dose. So this is a finding that we replicated because it was shown in the general population by then, also that people who were COVID-19 naive mounted an antibody response after the second dose of the 2 vaccine dose series, whereas people who had prior COVID-19 showed an antibody response with the first vaccine dose. It's still a 2 vaccine series. You don't have to skip the second vaccine dose just because you had prior COVID-19. Now, it was very encouraging. We were very happy that 95% patients had a response. And this finding was replicated by other studies who also showed antibody response to the vaccine in the same range of 80 to high 95%. Now, one thing that did stand out early on was that age was an important factor in the titers of antibody response, meaning older dialysis patients had a slightly more blunted antibody response to the vaccine compared to the younger patients. Not too surprising, but the key is that they still mounted an antibody response. And I want to add that mounting an antibody response does not equal to absolute protection against the virus, so we have to be careful with that. But this is the best measure so far that we have to measure vaccine efficacy. But I'll get into that in a second when I talk about transplant patients. So we were so happy that we had vaccinated the bulk of our patients, and now we felt they were protected, and we had the worst of the pandemic was behind us. What we also immediately recognized, because we were following these antibody titers on a monthly level on all our patients, and we started seeing them trending down within 3 to 4 months, which now we know is not a surprise, but at the time we were surprised how quickly these antibody titers were waning. And then what we didn't foresee is emerging variants, and that started happening pretty fast. So this became the perfect challenge where we then started experiencing breakthrough infections. And this is something we are still dealing with today. So then the big question is, okay, so they got a good response to the 2 vaccine series, but then the vaccine our antibody titers start to decline. So what is then their response to the 3rd vaccine? Because as you know, the boosters were approved last August for people who were at risk for severe disease or were immunocompromised. And by booster, I mean the 3rd vaccine dose. So this data was just published in CJASN earlier this month, where they looked at antibody response to the mRNA vaccine among dialysis patients. And you can see 97% patients within 14 to 60 days had a response to the 3rd dose of the vaccine. And in this cohort, they didn't see a difference between older patients and younger patients, which is very encouraging that older dialysis patients were able to mount an equally robust antibody response to the 3rd vaccine dose, which is the booster. This study is not published yet. It's still a preprint, because remember I told you, what does it really mean? Okay, we have an antibody response. What does that translate into in terms of actual infection? So this study, which as I said is still a preprint, looked at dialysis patients and what happened to them during the Omicron surge that we saw a couple of months ago, and it's still going on in one way, shape, or form. So about 3,500 dialysis patients who had antibody titers measured. And if you look, about 24% of these patients were unvaccinated, so they haven't seen the vaccine. About 51% have had 1 or 2 doses of vaccine. And then about 25% patients had a booster. So now let's see, during the Omicron surge, what happened to dialysis patients? So about 7% got infected, which is much lower. Remember, we were talking about very high prevalence, at least in the Northeast early on. So 7% got infected. Of them, 36% did require hospitalization, which is an interesting number, because that tells me that there were some patients who got infected who were at high risk for severe disease. So when they did the analysis, you can then appreciate that the risk of infection was highest among the unvaccinated and almost 2-fold higher. and risk of infection was about 30% higher if you had the 2-dose vaccine series but hadn't had your booster. And if the risk of infection, if you hadn't had an antibody response to the vaccine, then your risk of infection was, again, almost 2.5-fold higher. So now we know that it's the unvaccinated who are at high risk. We know that people who get the vaccine but don't mount an antibody response are at high risk, or people who have not had their booster are also at slightly higher risk compared to the patients who've had all 3 vaccines. So then the next issue is, what about transplant patients? And this was concerning in the beginning, and even now to some extent, that if you look at various studies, the antibody response rate among kidney transplant patients was anywhere from, in some studies, 10% to 60%. So much, much lower than what we were seeing in the dialysis patients. And this study looked at, okay, the 2-dose vaccine series didn't mount a response in an impressive number of patients. What happens when you give the non-responders a 3rd vaccine dose? Well, in this case, about 50% of the non-responders did mount an antibody response, but still about half of the non-responders didn't mount a response to the 3rd vaccine dose. So then what happens when you give a 4th vaccine dose? And now among 3-dose non-responders, the response rate goes up to 63%. So it seems like the transplant patients on immunosuppression needed more shots to mount an antibody response. And in this particular study, it's not a very large study. It's only 18 solid organ transplant patients, but this is the latest data that I was able to find, which was just published last month. So again, we know antibody response, but what does that translate into during the Omicron phase? So this is also a single-center study. So if you look at the middle row, 347 solid organ transplant recipients tested positive for COVID-19. 26% required hospitalization, and mortality rate was 2%. Now, look at the row below it. That is comparing it to the previous COVID-19 wave, the early on that we had from March 2020 to November 2020. So overall, cases are lower, 129. Then you go in the middle, 60% of them required hospitalization. And if you go further right, 10% mortality. So what this tells us is during the Omicron phase, which is something what we've seen in the general population too, that the infection rates are higher than before, but the hospitalization and mortality is lower. Now, whether it's the inherent nature of the variant, plus population is vaccinated, a lot of factors go into it, and it's hard to tease out. But this is what we are seeing in transplant patients. Now, why do transplant patients not mount a response? Not a rocket science sort of thing to figure out. They're on immunosuppression, and it's been shown that triple immunosuppression, MMF, high-dose steroids, B-cell depleting agents like rituximab, obinutuzumab, belatacept are all things that have shown relatively decreased antibody response to the vaccine. Also, old age, which we have seen in multiple populations, including end-stage kidney disease. So once we know which are the group of patients who haven't mounted a response and are at risk for severe disease, now we should be able to tease out which patients need COVID-19 specific therapies, which patients should also receive prophylaxis therapy and close surveillance. So people who are unvaccinated, people who don't mount a response to antibody response to the vaccine, and also patients who haven't received their booster dose, because remember I mentioned to you how the antibody titers do decline and how the risk of severe disease is higher among patients who are vaccinated but haven't had their booster shots. So a question that often comes up is which immunosuppression does what to the antibody response? So I'm not going to go into too much detail. This paper specifically looked at people on various immunosuppression for rheumatologic diseases, but what stood out is what happens when people are on rituximab or B-cell depleting agents. So about 4 out of 10 patients did not mount an antibody response. We've seen this in other studies that have come out too. And it's also seen that the response to vaccine changes depending on how long it has been since the patient got the B-cell depleting therapy. So the longer time that's passed, the better the chance that they would mount a response. And this is one of the reasons why sometimes we delay rituximab-like agents if we can when we are vaccinating the patients, or we repeat the vaccine series after a certain amount of time has passed since they got the B-cell depleting agent. So the next topic is a little hard to tackle. It's COVID-19 therapies, and the reason it's hard to tackle is it's evolving at a rapid pace because the variants are evolving at such a rapid pace. So the efficacy of treatment is literally changing from the SARS-CoV-2 variant. So as I said, it's evolving, and I still would say prevention is the best strategy. And when we talk about prevention, vaccination is the best thing to prevent severe disease. It may prevent you from hospitalization and death. So cannot emphasize that more. And anytime we see a patient who has COVID-19, immediately we are assessing the risk factors for severe disease, whether it's age of the patient, comorbidities, did the patient get a vaccine, did the patient mount a response to the vaccine? So there are lots of factors going into play when we are deciding COVID-19 therapies. So again, I cannot emphasize, people ask, what's the best pre-exposure prophylaxis? It's the vaccines. That's as straightforward as it gets. Now, there are other things you can get as pre-exposure prophylaxis, but who are the patients? It's patients who either can't get the vaccine or who haven't mounted a response to the vaccine. And those patients are solid organ transplant patients, and of course, as I'm in a cancer practice, so I know that CAR-T patients or patients who've had bone marrow transplants who are on high immunosuppressive agents are all at risk for not mounting an antibody response. So what do you do if you have such a patient? Well, there is a monoclonal combination of antiviral monoclonal antibody called Evusheld, which can be used even in dialysis patients if they are not vaccinated or if they haven't mounted a response to the vaccine. It's a single shot. There is no recommendation yet to repeat it, and the best data shows that the protection is there for at least 6 months. And I would strongly consider it in patients who cannot get vaccinated, because Dr. Campbell will talk about some patients who can have side effects of the vaccine, or like I said, if they are so immunocompromised that you cannot expect them to mount an antibody response to the vaccine. And I've seen this used a lot in stem cell transplant patients at Sloan Kettering. So right now, who do you prescribe COVID-19 specific therapies? And this is so confusing, and I won't go into what's happening with more famous politicians who get COVID-19 and they get the therapy, whereas some other patients can't because they don't meet criteria. But this is the problem, that we currently are told to provide COVID-19 specific therapies for people who are at risk for severe disease, and we don't provide it for asymptomatic patients, at least not yet. Now again, this may change, and literally these recommendations are constantly changing. So I've highlighted the 2 risk factors for severe disease that are relevant for this talk today, is chronic kidney disease and solid organ transplant recipients. They do fall in the category of high risk COVID-19. And NIH says if you have risk factors, you have to prioritize COVID-19 therapy. So these are gradations. So if you have a patient who's 75 years or older, that person would qualify for COVID-19 specific therapy. If the patient is 65 or older and has comorbidities, that person qualifies for COVID-19 therapies. If a patient is unvaccinated, they qualify for it. So this can sometimes be challenging, even for physicians, to figure out what is the best therapy depending on the risk. So I'm sure you've all heard about Paxlovid by now, which is a combination of 2 antiviral agents, and it's so far maintained efficacy even against the Omicron variants. And this is taken as a pill twice a day for 5 days. You should start it within 5 days of symptom onset, and so far the recommendation is not to continue it beyond 5 days. What is the problem for nephrologists? You can't use it in patients with a GFR of less than 30. And I have repeatedly asked this question to the community, is anyone using it at reduced doses? And I have not found anyone so far who has prescribed these agents. And if anyone has, I'm open to hearing about your experience. But one of the biggest problems with Paxlovid, besides the availability, which I think has improved over the past few weeks, is the drug-drug interactions. And that is something that we as nephrologists have to grapple with, and I'll talk about specifically calcineurin inhibitors. But if Paxlovid is not available, then remdesivir, which is an antiviral agent, even in the outpatient setting can be used. I want to emphasize that these agents are only for outpatient management. If you're sick enough to be in the hospital, you do not qualify for Paxlovid. It is not something that will be used for you. Now, remdesivir can still be used, but it's a different dose, but I won't get into that too much right now. So let's say you don't have Paxlovid, you don't have remdesivir, that's when you can use antiviral monoclonal antibodies. So we were happy, and actually we did use sotrovimab, but what is the problem with sotrovimab? It's lost its efficacy against the BA.2 variant of the Omicron virus, so that's not very efficacious anymore. So another approval was for Beptolovumab, which I haven't used yet, but this has recently been approved for the subvariant of Omicron that is circulating right now. And these can be used in CKD and dialysis patients, but as I said, these therapies are so rapidly evolving because the virus is so rapidly evolving that it's hard to keep up sometimes, and let alone know the availability and train your staff to do it. That's the challenge with this. So if the monoclonal antibodies are not available, then one can use high titer convalescent plasma. And at this point, I do refer patients to our infectious disease colleagues. And it's a specific criteria for convalescent serum, how high the antibody titers are in that serum, et cetera. A no-brainer, if a patient has COVID-19 and is on immunosuppression, we try to lower the immunosuppression, especially if they're on CellCept, MMF, prednisone if it can be lowered, and B-cell agents if we can not use or delay use of it. A few words about Paxlovid, because I think this comes up a lot because this drug is being prescribed quite a bit, or hopefully it's being prescribed more, is it's not approved for pre-exposure prophylaxis, so you can only get it if you have COVID and you're symptomatic. And if you get hospitalized in the interim, then it's up to the healthcare provider if they want to finish out the 5-day course, but the data there is not quite known. And for now, it's not approved for more than 5 days because I've been asked this question, can it be used for long COVID? So I will leave that indication separate. And when we talk about COVID-19 hospitalizations, it's also a tricky question because people get hospitalized for all kinds of things. The respiratory things is a no-brainer. Your oxygen sats are low, you have infiltrates in your lungs, et cetera. But as you all know, perhaps, that COVID-19 hospitalizations can be from hypovolemia, dehydration. Patients had altered mental status, had a cardiac event. So all of those are hospitalized patients, and all the therapies that I just mentioned may not apply to that patient population. So Paxlovid, unfortunately, so far can't be used in patients with GFR of less than 30. Between GFRs of 30 and 59, you can use a reduced dose. But the challenge with Paxlovid is the drug-drug interaction because it inhibits the cytochrome P450 system, so it delays the metabolism of drugs that are metabolized by the CYP3 system. So what does that mean for transplant patients? So if patients are on cyclosporin and tacrolimus, you should not be taking your usual doses during the time you're on Paxlovid. In fact, for tacrolimus, every center is a little different, but we hold the dose, and then after the 5-day course is done, we start measuring levels and then reintroduce the calcineurin inhibitors at a modified dose, usually depending on the levels. But the key is you have to monitor the levels, and this is not a guessing game where you can come up with a regimen because it would be different for every patient. So for our patient population, it's extremely important. I also want to emphasize that there's some medications you cannot use Paxlovid with, like amiodarone, flecainide, so some antiarrhythmic drugs are listed. So you need the assistance of pharmacy sometimes before you are able to prescribe this to patients who are on multiple drugs. I won't go into management of COVID-19 in a hospitalized setting because that's a different beast altogether. As you all know, dexamethasone, remdesivir, tocilizumab a lot of those agents have been used. So in summarizing, prevention of COVID-19 in patients with kidney disease, I cannot stress, is vaccination, vaccination, vaccination. Preventive measures can't be ignored to prevent super spreader events or even spread in the dialysis unit. So masking, surveillance, all those kind of things, avoiding patients coming into the hospital if they can be provided care in a telehealth fashion. Pre-exposure prophylaxis with Evusheld if the patient is unvaccinated or has not mounted a response, antibody response to the vaccine. And early implementation of therapy, especially if their GFRs are more than 30, with Paxlovid. You can consider remdesivir if Paxlovid is not available or can't be used. And as I talked about, monoclonal antibodies are also an option. So as a medical director of the dialysis unit, and we faced this early on in 2020, it's a multi-pronged approach. It cannot just be vaccine. You have to do masking. You have to, I can tell you how many hours we spent contacting drivers and transportation people to prevent people with COVID to be allowed to sit with people who didn't have COVID. We changed the setup of the dialysis unit to create more 6 feet or longer distance between chairs. We did surveillance on all our patients pretty much every week so we can catch asymptomatic cases. And then staff, you saw other infections, flu basically disappeared in 2020. It's because of better hygiene practice and masking and hand hygiene. And staff should be willing to give some of these antiviral therapies, and if they're not willing, then you can provide a lot of these therapies to dialysis patients. And then, of course, disinfection, sanitization, all those factors go into play to protect our end-stage kidney disease patients from this disease. So with that, I'll hand the mic back to Dr. Campbell, who will talk about COVID-19 and glomerular diseases. Thank you.
Thanks so much, Dr. Shaikh. All right, so as Dr. Shaikh mentioned, right, patients with kidney disease, whether they're on dialysis or recipients of a kidney transplant, were uniquely susceptible, right, to COVID-19 infection and severe consequences. And we definitely saw that throughout the pandemic. And unfortunately, this resulted in some more susceptible patients of persistently decreased kidney function, right, post-infection. I spoke in the talk earlier about this collapsing glomerulopathy phenotype that we saw, right, in patients who had 2 APOL1 high-risk alleles. This did not happen, very frequently, but there were some centers that reported small numbers of cases of patients, and again, this was from New Orleans, where 4 of the 6 patients who were studied here actually ended up becoming dialysis dependent, right? So having APOL1, subsequently getting COVID-19, enhanced inflammatory cascade being activated, multi-organ system failure, leading to dialysis dependence, unfortunately. And as I mentioned earlier, we also saw one of our patients who ended up being dialysis dependent, who had in the kidney tissue on biopsy some downstream signaling cascades that were similar to what we saw with HIV-associated nephropathy, with phospho-STAT3 expression being up in the glomerular and tubule, so suggesting this viral genomic interaction having some similar characteristics for these 2 disorders. So, we've also been learning a little bit more about the pathology that we see, right, in patients with COVID-19 infection. And this was a multi-center review of patients who had COVID-19 disease, acute kidney injury, and kind of looking at what the biopsy features were. And in fact, collapsing glomerulopathy was one of the more common pathologies that we're seeing, but not the only one, right? There are also, other features of, CAS nephropathy and this proliferative glomerulonephritis with immune deposits that we're seeing as well. There was not an increased prevalence of diabetic kidney disease, IgA nephropathy, that were seen in patients who had COVID-19. And another multi-center group kind of looked at what happened to patients with glomerular disease after they got COVID-19, really trying to get a sense for disease progression, whether or not the acute kidney injury that developed in some of these patients was more severe or, leading to more prolonged, decrease in kidney function over time. And what this smaller series showed was that, in fact, patients with FSGS or minimal change disease or higher levels of proteinuria, they seem to have a more prolonged decrease in their GFR for a longer period of time post-infection, right? So, the take-home message from this study was closer monitoring, right, should be performed in patients with these underlying diagnoses with heavier proteinuria, and certainly highly relevant to this audience. And I think many of us have read about some of the rare associations of glomerular disease with COVID vaccinations, right? There were several case reports, and including one from our group as well, describing patients who did not have a history of glomerular disease, who had minimal change disease or IgA nephropathy, and these were probably the two most common diagnoses that we're seeing post-vaccination, right? And it definitely caused a little bit of an alarm early on, right? How prevalent is this? What's going on? Why is this happening? And I think fortunately for us, it's quite rare. It seems that the vast majority of patients who get this glomerular disease developing just maybe an unmasking of something that was actually there to begin with, but pretty responsive to treatment, right? So this was sort of the question in a letter to the editor in Kidney International, is it's sort of an unmasking subclinical disease. And we're talking this morning about, the underlying, histologic changes, inflammation that's happening that may not actually result in proteinuria or decreased kidney function quite yet, but perhaps getting a vaccine in certain patients by boosting the immune system, you could sort of bring out this phenotype, and then you're seeing the proteinuria and in some cases decreased kidney function. But again, it does appear to be transient and pretty responsive. And this was, a study kind of bringing together and looking at all the reported cases. And again, the most common diagnosis that was seen was IgA nephropathy. I think this was one of the 52 cases when the literature review was done. There were some reports of membranous nephropathy, and minimal change, again, was quite prevalent. But I think, here it is, more than 80% of the patients had a very mild course, very responsive to treatment. And again, this was another study looking at the temporal association, and this was from our kind of labs, which a very high volume kidney biopsy practice, and they were looking at the relative numbers of different diagnoses pre and post pandemic, IgA nephropathy, minimal change, and there wasn't really an increase. So whatever we're seeing with some of these new cases, if you will, of IgA nephropathy and minimal change, it didn't put a dent in the relative prevalence of these diseases. So again, confirming that these are just rare occurrences and really no cause for alarm or concern with getting the COVID vaccine in patients with underlying glomerular disease. And this was really a question that we wanted to answer for the benefit of our patients. So I think with that, I'll pause, and we're happy to answer your questions. Josh, you must have one. I know.
So, question of mounting antibodies in patients with, are there differences in the type of immunosuppressant drugs? See more with Pacslovid?
So it's been seen most with antimetabolites, so more with MMF than with CNIs like Tacro and cyclosporin. The rheumatologic disease paper that I briefly touched upon, calcineurin inhibitors were not discussed, but that data comes from transplant patients. But within the rheumatologic group, where they're on a wide variety of immunosuppression, from anti-TNF agents to JAK inhibitors to rituximab, obinutuzumab, high-dose prednisone, It was the B-cell depleting agents that stood out the most, rituximab-like agents. JAK inhibitors also had a blunted response. Interestingly, anti-TNF agents did not seem to blunt the antibody response to the vaccine, so Humira, Enbrel, those kind of things did not. Within the transplant population, in terms of, it's really more the strength of immunosuppression, so triple immunosuppression, lower antibody response. So triple immunosuppression would mean PRED, CNI plus antimetabolite like MMF. MMF in itself stood out, belatacept stood out, which is supposed to be less immunosuppressive, but even that is a risk factor. So I think it's really the overall, in at least solid organ transplant patients, the overall immunosuppression state. In rheumatologic patients, I think there's more variation depending on which agent they're on. And I think the other important caveat to that is we are just measuring antibody response. There are other cells called T cells in our bodies, and that response has been measured in a subgroup of dialysis patients from the Imperial group in London that did show that patients whose antibody response weathered off in dialysis, among dialysis patients, some of them still had a T cell response. Whether that translates into protection against severe disease and death, we don't know. But T cell responses are a little harder to measure. There's no antibody titer. It's a different test. So we don't know enough. But so far, the antibody titers do seem to correlate somewhat, not perfectly, towards severity of disease.
I have another question. And first of all, thanks for your presentations. The question is about COVID nephropathy in terms of what the registries are showing. And then secondarily, are any of these clinical trials that are now being studied for different GN diseases, are these being looked at potentially for COVID nephropathy? Thank you.
Yeah, no, that's a good question. You know, a lot of we're kind of gathering a lot of this information because it is still not very common, right? The COVID-associated nephropathy, and I think you know, the collapsing GN that I mentioned certainly was a more severe form, and that really seemed to be limited to patients with the 2-APOL and high-risk alleles. And again, a very small minority of patients with the high-risk alleles. So it's really, again, a very severe phenotype, but in a very small population. The other interesting thing that I would say is that we saw a lot more of this during the first wave, right, of the pandemic. I think the subsequent variants, we've not seen as much, certainly not as much acute kidney injury, period. And you've seen the difference in the phenotype from a pulmonary perspective, right? It's more of an upper respiratory rather than a lower with pneumonia. So as these new variants and subvariants emerge, we're seeing a different phenotypic readout. And so this may become, you know, even less common. And the other thing is the management off the bat has changed, right? You know, I recall during the first wave, and Dr. Shaikh will see the same thing. You know, the management was all over the place for patients. There were multiple clinical trials that were ongoing, but we have a very strict protocol now, right, with, you know, certain types of steroids being used off the bat to decrease that cytokine response. And we're just not, fortunately, we're not seeing as much of kidney-associated manifestations as we did earlier. That could change, of course, you know, with new variants emerging. Yes.
For Dr. Campbell, and by the way, excellent presentations from both of you. Thank you.
Thanks.
In an individual with underlying glomerulonephritis, do you see an increase in proteinuria with the vaccine or with the booster?
That's a great question. I think most of the reports that I presented and the ones that we're seeing, it was mostly de novo. It was mostly individuals who actually didn't have a prior history, right? There was one you know, flare in a transplant patient that was among the case reports. But this is understudied. Again, we're in the rare kidney disease space, and we do have to you know, be assertive in getting our stories told. So there's certainly more than one consortium out there looking at this very question. You know, and so we should get more information. I showed you one such study showing that patients with FSGS and minimal change disease may have had a residual kidney function decline, but it didn't seem that the proteinuria flared per se with infection or with the vaccination, right? That's still unusual. So again, the take-home message is that it does appear to be safe to get the vaccines that are out there, as far as we know at this point.
And for those of us who are conducting clinical trials, I presume your advice would be to allow immunizations and boosters during that clinical trial.
Yeah, that's also a very key point. We're documenting, and of course, we recruited for all our clinical trials, before, during, and up to the current time. And we've had patients who have gotten COVID-19, and we encourage patients to get vaccinations. We just want to document the timing, right, of when the vaccination happens. So, for example, IgA nephropathy, as I said, one of the associated, disorders where we did see some patients getting that diagnosis. So we wanted to document the timing of the vaccination for patients with a history of IgA nephropathy. We didn't really, for the ones that we had in our trials, see a flare of proteinuria, but it would be something that certainly the study sponsored, the medical monitor, the clinicians want to be aware of, just in case we saw a bump in the proteinuria post-vaccination. We would know that possibly there could be something that we could look at in terms of an association. But yes, we absolutely encourage vaccinations and routine clinical care, during the trial period.
Thank you.
Thank you.
So we've seen patients that are compromised that do not show any physical response after the vaccination, as we have in a lot of elderly people with lower immune systems. Is there a correlation between antibody response and having no symptomatic adverse reactions after vaccines?
That's $1 million question, because when trials were done, they just looked at severity of disease, hospitalization, mortality. They did not give us the antibody data. On the other hand, I can tell you, and this is not from a trial data, this is from our practice data, because we were monitoring these levels on every patient every month, sometimes even more frequently if we suspected they could have acquired a new infection, and that's when the anti-nucleocapsid antibody would go up within 14 days. So what we've seen is clearly among the unvaccinated, the severity of disease was high. The data that I presented, and this is again the variation among the variants where this data, because remember the original vaccine trials were during the original wave of the Wuhan virus. Now the virus has changed. So the data I presented about among end-stage kidney disease patients during the Omicron surge, which is a different virus almost now compared to when the vaccines were tested, we still saw a link between disease and unvaccinated state and plus disease versus people who didn't mount a response. So the severity of, or rather the risk of infection was higher, 30% higher in people who had the 2-dose vaccine but didn't mount or had the booster and did mount an antibody response. So the point is, there seems to be a correlation, but there's no head-to-head comparison between this patient had this much antibodies and this patient did not, and hence the severity of disease was different between the two. As a group, there is a correlation, but I've seen patients who are admitted with more than the cutoff antibody titer and end up with severe disease. These are generally immunocompromised patients. And remember, I work in a cancer hospital, so I have stem cell transplant, kidney transplant patients who are admitted despite having had antibody titers that are measurable. So yes, as a whole, it does seem to be protective, the antibody titer, but do I have a cutoff saying if you have an antibody titer of that much, you are protected? No, because we don't know what is the cutoff for a protective antibody titer. So one of the caveats with all these studies is everyone's using a different assay, everyone's using a different cutoff. So it's very difficult to decipher the antibody cutoff titer and protection from the disease. But there is a correlation. If you mount a response, you're more protected than you don't. And that's also a little difficult with each variant being a little different than the previous one. Will it hold true for the next variant? It's hard to say. So I hope I've answered that question, but it's a tough one to answer because the trials did not report the antibody titers in these patients. Josh.
I think Josh has a question. Yeah.
So I think a good practical question for folks right now, the fourth dose. What kind of kidney patient qualifies for the fourth? Let's say you're in remission and you're not actively spilling. So what's the current wisdom?
So for my practice, it's straightforward. CKD patients who are at risk for severe disease, and if you look at the risk factors for severe disease, it does include people who are on immunosuppression, and it does include people who have chronic kidney disease. So for my practice, I would administer the fourth dose to the dialysis patients now that it's been approved. And anyone who's on immunosuppression, I would, without checking their antibody titers, because I don't know what antibody titer is protective. And that's the best I can advise. It may not be the perfect advice, but because I don't know what the cutoff neutralization antibody titer is, and if you are in the high-risk group, then fourth dose makes sense, because we know the response to the vaccine seems to wane every 6 months with this vaccine. So.
Yeah, and I would absolutely say as well, patients with glomerular disease in our practice, we do encourage that fourth dose, as Dr. Shaikh said, right? I mean, that falls under the CKD realm, and certainly those patients would be on immunosuppression possibly, or may become candidates for immunosuppression down the line. So good idea to be as protected as possible. So.
I was going to ask my wife, but I figured I'd ask the professionals. There's a correlation that I've been told between rituximab and the boosters. I've gotten different answers from different people and different doctors that have said, yeah, you should be fine, go ahead and get your boosters. And then the other one says, no, you've already had rituximab, don't get any boosters. Can you guys speak to that at all?
So we might have different answers for this too, so let me go first. So
Wouldn't be the first time.
yes, that wouldn't be the first time. The story with rituximab is that we know it blunts the response, but half the patients did mount a response while they got rituximab. It seems to be the time frame, the duration of time between rituximab and the vaccine that determines the response. So I've had patients who, if let's say they're on treatment for something that I don't want to hold rituximab, I would counsel them. I would tell them it's possible you may not have an antibody response. I would still give it because patients can, like in the rheumatologic study, about 60% people did mount a response, and the only thing that factored in was people who were 6 months out of Ritux infusion had a better antibody response versus not. So, and if they don't look, I mean, within 2 to 3 weeks of the second dose, you know if patients are mounting a response or not. You can give them pre-exposure prophylaxis with Evusheld. That's not, we've had stem cell transplant patients with that have gotten it. And then once you're far out from your immunosuppressive therapy, you can get a repeat vaccine dose series at that time. So that would be, because patients getting rituximab are also at high risk for getting the infection. So I don't see any reason why pre-exposure prophylaxis, such as Evusheld or vaccines should be held in that situation. Of course, the response would be lower compared to someone who's not on rituximab.
Yeah, completely agree.
That's a rarity. But